welcome to our second Engineers Without Borders Global Seminar. We're excited to have not only members from our club, but members from the broader Georgia Tech community. And these seminars are really a way to help introduce us as students and members of our community to sort of a globally focused context and help make us more globally conscious citizens. I'm really happy to introduce Dr. Rudy Gleason, who works in both the School of Mechanical Engineering and the Biomedical Engineering Department here at Georgia Tech. And Dr. Gleason works on different modeling frameworks for biomedical applications. And he really focuses on translating a lot of those biomedical frameworks to implementation in developing communities and developing countries. I actually had the pleasure of working with Dr. Gleason several semesters ago, and I'm always amazed by the innovative, interesting work that he's doing here at Tech and around the world. And he actually recently received a really large grant from the Gates Foundation to develop wearable technology in Ethiopia, and a lot of the work he does focuses on helping developing communities in Ethiopia. So I, for one, am really eager to hear from him today. So with that, Dr. Gleason, take it away.
Awesome. Well, thanks. Hey, thanks for thinking of me to come and speak at EWB. As you see my talk, EWB is kind of part of my story in global health a little bit. And let me just share some slides. Let's see how this is going to work. Try this one, I think. Let's try this. Right, and then is that working? You guys see my slideshow?
Yep, that's great.
Awesome. So, hey, I just wanted to introduce you guys to somebody. This is Kennedy. This is Kennedy. When she's an orphan. She was an orphan in Ethiopia, and this is when she was living in an orphanage in Ethiopia. And my wife and I were in the process of adopting her, and we got these pictures of her. We hadn't met her, been introduced to her yet, but we got these pictures of her, and my wife and I totally fell in love with this little girl. And you might be able to see from this picture, she was really malnourished. You can see her got really skinny arms, and but she was our daughter. This was in early 2009, and we were going to about to go travel to bring her home. But in April, she passed away before we could bring her home, and obviously my wife and I were totally crushed at the loss of Kennedy. And honestly, we were pretty ignorant at sort of the global health issues around the world. This is a slide of the child mortality rate around the world just around the time when we lost Kennedy. It was actually the year after. And you see the countries shaded in black. They have a child mortality. They had a child mortality rate of 100 per 1,000 live births. That means in those countries at least 1 in 10 children didn't reach their 5th birthday, which was absolutely insane to us. Those numbers were absolutely insane. And around the time in 2010, there was 8 million children that died around the world, and about half of those occurred in sub-Saharan Africa and another third in South Asia, Southern Asia. So, and less than 1% of those child deaths occurred in high-income countries. And in Ethiopia at the time, it was 1 in 6 children that didn't reach their 5th birthday. But these numbers were crazy to us, and my wife and I and my family were sort of motivated to try to figure out how we can be part of the solution. At that time at Georgia Tech, we were just talking about this before we started the talk. I study vascular disease in my lab. I study diseases of the cardiovascular system, and I teach mechanics classes, and I still teach these classes. But I started asking the question how I can help be part of the solution to addressing some of these grand challenges in global health that disproportionately affect Ethiopian and other developing countries, how can I integrate that in what I do at Georgia Tech? So um, this is actually a picture of EWB, the Cameroon project, and this is me. And this was one of my first trips to Africa, actually. And went with these four students, Courtney, Andrew, Emily, and Molly. And this Cameroon project, the goal of the project, you guys may know about this project, I'm not sure, but the goal of this project was to bring water to this village in rural Cameroon. And this was their existing water system. It was a spring catchment system. But anyway, I actually went on a couple of trips to Cameroon with EWB, and it was sort of part of my story in discovering this. And it was amazing couple of trips. These were our hosts, and we were kind of proposing some solutions for these guys, and we were trying to figure out what we were gonna do. And we got to goof off with a bunch of kids while we were there as well, which was the best part of the trip. Um, but I love this next picture. This is a picture. This was in March 2010, and this is Andrew when he was a student at Georgia Tech, and this is in March 2020, just earlier this year. I had a trip to Ethiopia and then Nairobi, and Andrew and Emily are both working in Nairobi still, 10 years after they were students at Georgia Tech. Some of you guys may know their story. This is the Sanovation guys. These guys, when they were students at Georgia Tech, their senior design project was to develop a solar latrine. And this latrine that they designed for their project, I think they did really well. Like they won the expo, or I don't know, they won a bunch of stuff at Georgia Tech in terms of senior design competitions. And they actually went on and got a small grant, and four students, Emily and Andrew and two other students, actually moved to, I think it was Chile, for like 6 months to try to get a company around these solar latrines that they developed as part of their senior design project. And fast forwarding ahead, they ended up going to Kenya, and now they have this company that's in Kenya. It's this growing company. It's kind of they've been in Forbes magazine, and as you know, they've been publicized as some of the most innovative companies in Kenya. Anyway, I got to see this Andrew. I didn't get to see Emily. She was outside of Nairobi in March, so it was great to catch up with those guys. Um, one of the things to sort of help be part of the solution or to do something around this area was in the area of teaching. We were talking earlier, shortly after we lost Kennedy, I started developing this course called Global Health and Engineering that sort of explores the interface of global health and engineering. And I told you, I don't know if you guys know this or not, but I told you kind of early on, we were very ignorant about this, just the global health disparities around the world. And I'm not sure if you guys know this about Georgia Tech, but when you don't know anything about a subject, the first thing you do is teach a class on it. That was meant to be a joke, but I can't see if you're laughing because we're on Blue Jeans. So um, the students in my class may actually recognize this to be the truth. But anyway, this has been a really popular class. I started it 10 years ago, and we've had at least 10 course offerings, I think, since then. And usually it's pretty full, 30, 40 students in the course. Also, I've done a bunch of undergraduate and graduate research experiences. Manab mentioned that he has done some undergraduate research in our lab. A lot of students have actually gone to Ethiopia. This is a picture of my graduate student, Alex. He's now working for Medtronic. He's got his PhD, and he actually proposed to his wife in Ethiopia. It was his girlfriend at the time, but he proposed to her in Ethiopia, and a bunch of other students. This is Marnie, and this is a senior capstone design team that we actually took to Ethiopia. I'll talk about that more on the next slide. These guys, most of you guys know about capstone design. James Stubbs, who is in biomedical engineering, he and James Rains really run our capstone design portfolio in biomedical engineering. And James Stubbs had this idea of developing a capstone section really focused on low and middle income settings, developing biomedical devices for low and middle income settings. And so James and I, over the past couple of years, obviously not last year, but the previous couple of years, had taken senior design capstone students to Ethiopia to sort of do their clinical discovery and clinical immersion with some of my collaborators in the hospitals and healthcare settings there. And so it's been really cool experience. So that we've had a couple teams travel, and we're hoping next summer, hopefully, fingers crossed, we can revamp this. These are just two of the projects that came out of these capstones. One was Team Libby. Their goal was to develop a low-cost, easy-to-use monitor to monitor fetal heart rate during labor and delivery. And so this is just a picture of their device. This actually, the silver part has very little to no function for this device, but this is called a Pinar horn, and it's a horn that clinicians in Ethiopia actually use. They hold it up to the mother's belly, and they listen for the heart rate of the fetus, and they can actually hear it, and they can count the heart rate sort of just audibly. And so we wanted to replace this. We wanted to keep it something similar to what the local clinicians are used to, but actually all the action happens in the puck. We call it the puck. It was essentially a microphone in there. The second team, the goal that they were after was to develop a device to prevent neonatal hypothermia during these sort of intermittent periods of transport and surgery. A lot of you guys may be familiar with what's called cold chain when we talk about vaccines or medicines that need to be held at a certain temperature as we transport them and get them to the point of care. In hypothermia, we talk a lot about warm chain, and a neonate can become hypothermic literally within 5 to 10 minutes, and especially a low birth weight neonate can become hypothermic very quickly. And so the first few days or first hours and days and even the first week of life, it's important to keep a neonate warm, and it's called warm chain, to keep that neonate warm for the first 7 days of life. But there's often periods, especially in low resource settings, where the neonate needs to be moved. Maybe they're transferred to one unit to another, or one hospital to another, or one place to another, or maybe they have to have surgery. In these sort of intermittent periods, there's really no thermal care strategies in Ethiopia. And so this team developed essentially a warming pack. I'm not sure if you guys remember or have ever seen the little things that you stick into your gloves. You pop them and you stick them into your gloves, and they warm up. Well, this is basically the same idea. This pack is about 6 inches by 6 inches, and it's made of a solution that we can actually manufacture from local resources. We just need baking soda, vinegar, and water, and some cooking, and you can make the solution. And then when it's activated, it crystallizes, and when it crystallizes, it releases heat. But the advantage of this device over sort of the traditional glove warmers is it's actually reusable. So if we simply boil this bag after it's crystallized and releases heat, it turns back into a liquid, and then that liquid can be reused again by activating it. So really cool solution that this team came up with. And we're in the process now of trying to secure funding to conduct some pilot studies with this device. So and so that's kind of sort of the teaching space. A little bit of the service space I didn't talk too much about. So I definitely got involved in EWB early on, and then my wife and I also started a nonprofit organization that works in Ethiopia that really focuses on women and family empowerment and caring for orphans and things like that. The third area of what I do at Georgia Tech is research. So that's mostly what we do as faculty at Georgia Tech. And as I said earlier, we do a lot of sort of biomechanics and mechanobiology really around vascular diseases, and we still do a lot of this work. We have active grants and proposals and graduate students doing this work. But today I wanted to talk more about some of the work, sort of the second aim that developed in our lab over the years of really developing innovative bioengineering strategies to improve maternal and child health in the developing world. And here are a few projects. Actually, I'll touch on this third one, but we won't talk about it too much. But two projects that we have ongoing in our lab. The first one is this is a picture of my family. So kind of continuing the story from Kennedy, we actually did adopt two daughters. This is Isabel and this is Brooklyn, and these are my two boys, Lawson and Eli. This is an old picture. This was probably 2011, 2012. So this guy just started high school this year, and these guys are in middle school, and Brooklyn's in elementary school. But I'm showing you this picture actually to highlight my wife. You may notice from this picture, and those of you that know me know I'm not very tall. I'm only about 5'9". So my wife is under 5 feet tall. She's under 150 centimeters tall. And when she was pregnant with our first son, with Lawson, we delivered in Atlanta at Northside Hospital. And her obstetrician said, we're going to have to keep an eye on you. You're a small woman and you have a normal sized baby. You're probably going to need a C-section. But we were delivering. Northside Hospital at that time had the highest number of deliveries in the U.S. I think it still does. And he said, I'm gonna let you try labor. A lot of times, small women can deliver large babies, but if you fail to progress, I'll wheel you next door and we'll do a C-section. And that's exactly what happened with our first son. And but if that happens in rural Ethiopia, where emergency C-section may be hours or days away, the mom dies, the baby dies, or both. Essentially, the baby's just too big to make it through the pelvic passage, and the mother pushes and pushes until either the baby suffers serious damage, or the uterus can actually rupture and the mother dies. So it's a really big problem in Ethiopia. It actually occurs a lot in places where women are small in stature, which is the case with a lot of Ethiopian women, but also where women marry and have children at a young age, and also in places where malnutrition, there's a history of malnutrition where children don't have, their pelvises actually don't, women's pelvises haven't developed because of malnutrition. And so this is a big problem worldwide, about 8% of maternal deaths, but in Ethiopia, on average, is about 11%, but there's places in Ethiopia where 20 to 25% of maternal deaths are due to what's called cephalopelvic disproportion, or I'll call it CPD. And so over the last 100 years or more, there have been significant efforts to sort of correlate the risk of CPD-related obstructive labor well before the onset of labor for just the reason I described. And radiological pelvimetry using X-ray or MRI or CT to carefully quantify the size of the pelvis, maybe the size of the fetus, and then predict which women are at most risk. It's also a clinical pelvimetry. It's a physical exam given by an obstetrician where they use palpitations to estimate the size of the pelvic passage, and then anthropometric measurements. I mentioned, well, my wife is under 150 centimeters. That's actually a risk factor for cephalopelvic disproportion, just the size of the woman. And there's been a bunch of risk factors published, even things like shoe size. The size of a woman's shoe correlates with her risk of CPD. So there's challenges with all of these methods. Obviously, radiological pelvimetry requires high resource equipment. Clinical pelvimetry really is just not that accurate when it comes down to it. And anthropometry, at least the current methods are fair predictors, but they're not really good predictors. And the reason for that is often they're considered just single measurements like height or shoe size or things like that, but they're not considered in combination. And I think another reason is maybe that there's a diminished need for assessing risk of CPD in places like the U.S. and in Europe and many developed countries. There's nearly universal access, if not universal access, to emergency C-section at the time of delivery. And so if we have something that's only an okay predictor, and we don't really care anyways because we can always wheel the the mother next door and do a C-section because it's available, then it's sort of lost its need in developed world settings. But in developing world settings, it's really a critical issue and something that I think is overlooked. So here's our proposed solution for this problem. We've developed a technology based on 3D cameras. We started out using the Kinect 3D camera. This is a camera that we use for Xbox One, right? You just dance in front of it. And we started out using that, and this is an image of a woman where she was standing with her back to the Kinect camera. We also do front and side images. And then more recently, we moved to a smartphone-based 3D camera. This one's called a Structure 3D camera, where essentially the camera can connect just to an iPhone, and you can scan and generate a 3D model of whatever you're looking at. In this case, a pregnant mother in Ethiopia. And then in parallel, we also took just sort of traditional tape measurements, and we took a number of measurements that anyone that we think may be important, and collected a bunch of data. And we performed a couple of studies. The first study, we compared the Kinect camera. The Structure, actually, when we did the first study, wasn't even available. It wasn't on the market yet. So the first study used the Kinect camera, and we also did MRI pelvimetry, clinical pelvimetry, and then all these traditional anthropometric measurements. And this is a receiver operator curve. I'm sure many of you are familiar with what this is, but essentially assesses the strength of the predictive capability of the metric that you're using to predict. And just to kind of describe this, I'll show this in a couple more slides as well. This plots the true positive rate versus the false positive rate. And so a perfect predictor, you would be able to detect all of the true positive cases before you detected any false positive cases. And so a perfect predictor would go straight up and straight over. And then I put this diagonal reference line. This is essentially a predictor of flipping a coin. So this is sort of 50-50, you know? And so the further the curves are up and to the left, the better predictors they are for these receiver operator curves. So just a simple explanation for what this is. And so this first study, it was just on 287 women, but this first study showed that first of all, all the black curves are published risk scores that had been in the literature. And so height alone, you can see that height alone actually is not a horrible predictor of CPD, as we said and as we suspected. And same thing with clinical pelvimetry. This is called fetal pelvic index. This is actually one of these published metrics from MRI pelvimetry. Actually didn't do very good. It's a ratio of the size of the fetus's circumference of its head to the circumference of the pelvis, and there's a few different circumferences that it looks at, but anyway, it's the ratio of the size of the fetus to the size of the mother's pelvic passage. And then we developed 3 novel risk scores, one based on a whole bunch of anthropometric measurements in addition to height, one based on a whole bunch of measurements that we took from MRI images, and then one based on a whole bunch of measurements that we took from Kinect images. And the point of this slide is to show that that both MRI and our novel Kinect tool perform better even than our novel anthropometric measurements, and that Kinect and MRI were sort of on par with each other. And then the second study that we did, we sort of dropped the MRI and the clinical pelvimetry just because of cost and time to do those. But we added another 685 women where we looked at Kinect, anthropometry, and this is where we also added the Structure camera. And we've developed risk scores that have even further improved sort of the predictive capabilities of our tools. And so just to give you an idea, the area under this receiver operator curve, this area under the curve, is an indicator of how predictive a model is. And so a predictor with an area under the receiver operator curve of above 0.9 is considered an excellent predictor. And so what this shows is we can sort of detect about 70 or 80% of the cases with maybe about a 5% false positive rate. In other words, we'll get 70 to 80% of the CPD cases, or maybe I think it's 75% here. Um, at the same time, we'll predict 5% of women that actually don't have CPD related obstructive labor. Another important part of this curve to us is this line right here, and I call this the triage rate. So these are actually all negative. These are all the negative cases, and so in other words, we get 1 minus say 0.35, so we get 65% of the women that we correctly diagnose as low risk before we get any women that we incorrectly diagnose as low risk. So this triage rate is something that's very important to us as well, because we also want to not have to refer women to the clinic if they really don't need it for at least for the case of CPD. So we published a few papers on this, and here are a few, and recently it looks like we're going to be getting a large NIH grant, large R01, to actually push this device forward, and our hope is over the next 5 years to actually have this device in clinical use in Ethiopia. The goal of the, I don't think I have it in here. The goal of the, maybe I do. Yeah, the goal of the study is to, all of that work was conducted. We're pushing it in 3 different directions. One, we're increasing our sample size almost by 7 or 8 fold. All of our previous data was also done at term, at gestation, and so now we're pushing back in gestation. So if we can diagnose earlier in gestation, there's an advantage to doing that. And then we're going across 6 different sites in Ethiopia. The reason for that is the people groups that live in these different regions of Ethiopia are very distinct in terms of their size, in terms of their behaviors, like delivering in a health facility or not delivering in a health facility, but also things like the prevalence of CPD in these different regions it differs. So we want to develop a tool, at least at this point, we want to develop a tool that's valid across all the people groups in Ethiopia. All right, so let me shift gears and let me keep an eye on the time as well. So the second project, or the second sort of clinical problem that we're interested in, is called preeclampsia. Preeclampsia is essentially pregnancy-induced hypertension. It's I've probably got a slide here. It's the onset of elevated blood pressure or hypertension that starts after 20 weeks of gestation. So gestation is about 42 weeks, even 36 weeks to 42 weeks. So about halfway through pregnancy, you get this large increase in blood pressure, and so, at least one of these other conditions needs to occur for it to be considered sort of preeclampsia. And preeclampsia, it's the second leading cause of maternal mortality worldwide. And in developing countries, women in developing countries are 7 times more likely to develop preeclampsia compared to women in developed countries. And it leads to one of the main causes of death it's called eclampsia. It's actually seizures in the brain, and that can lead to death. It also, here's some of the other causes of death with preeclampsia. And I think I sort of mentioned early on, but my lab sort of historically has studied vascular remodeling, how blood vessels grow and remodel both in health and disease, and how remodeling mechanisms play a role in disease. Well, it turns out that preeclampsia is actually a condition of impaired vascular remodeling, and so this is the uterus of this is a cartoon of the uterus, and the uterus in a woman that's not pregnant, maybe about the size of my fist, and then throughout gestation, this uterus grows to be something that is big enough to hold a baby inside, so maybe about this big. And so it grows in diameter about 3 to 5 fold, and it grows in length about 3 to 5 fold. And so the vessels that sort of transverse this uterus have to also grow tremendously, it just to sort of keep up with the growth of the uterus, or the stretching of the uterus as the baby grows inside. But I think more importantly, the blood flow through the vasculature that is in the uterus. There's a placenta that is associated with the exchange of oxygen and nutrients and waste between the fetus and the mother. The blood flow through this uterine vasculature increases about 15-fold, which is crazy. There's nothing else in the body where the blood flow changes by 15-fold. And so, in addition to growing lengthwise, the caliber of these arteries has to grow significantly, maybe 2 or 3-fold to accommodate that increased blood flow. And when this remodeling, this growth of the vasculature is impaired, what happens is, you guys who've taken any fluid mechanics classes know that if you have a peripheral resistance and you're trying to get flow through it, and the peripheral resistance remains high, the only way to get flow through that high resistant tube or something is to increase the pressure gradient, right? So we have to increase the pressure gradient to drive more blood flow through that high resistant vasculature. And that's essentially, in a nutshell, what happens. Mothers essentially increase their blood pressure so that they can get more fluid exchange to the placenta. So the other thing that happens in this impaired remodeling is what's called intrauterine growth restriction. So the mother doesn't get hypertension, and there's not enough nutrient and waste exchange at the placenta. So this is the disease that we're trying to study, or the pregnancy condition that we're trying to study. And a really important trial was conducted a few years ago, where they showed that actually low-dose aspirin can be used to prevent preeclampsia when we can identify women that are at high risk. So if we give high-risk women low-dose aspirin starting at around 12 weeks gestation, then and just low-dose 150 milligram per day aspirin throughout gestation, it actually reduces the incidence of preeclampsia and reduces the severity of preeclampsia. What our lab is interested in is developing tools that can be used in a low resource setting that we can identify the risk of preeclampsia early enough in gestation so that simple interventions like low dose aspirin can be used. This is another cartoon of the uterus and the vasculature, and this is one sort of fairly good risk assessment predictor called the pulsatility index. This is a Doppler ultrasound, and with the Doppler ultrasound, we look at the blood flow in this artery. It's called the uterine artery, and so this is over the cardiac cycle. There's a systolic blood. This is blood velocity, centerline velocity through that artery, and then in diastole is here, systole, diastole. And the ratio, maybe I've got it on the next slide, the ratio of the peak systolic velocity to the end diastolic velocity, so the ratio of this number to this number, called the pulsatility index, where there's a couple resistance index. And it's an indicator of the resistance, the peripheral resistance downstream of that vessel. And when this pulsatility index is very high, it indicates that there's high distal resistance, and when it's lower, it indicates that there's lower resistance. So, kind of a long story, but here's a plot of the pulsatility index versus gestation from one study, and we can see it drops significantly. And actually, if you go back to starting at 0, it's not on this plot, but if you start at 0, it starts way up here, and then it drops significantly over the first 12 weeks of pregnancy, and then continues to sort of asymptote to a value of about 0.75 or so. But at this time point, which is where we're really interested in, women that have a high pulsatility index at 12 weeks gestation are considered sort of high risk for developing preeclampsia later. And so this is one indicator. There's also other indicators of, I guess I don't have it in here, but there's a few circulating biomarkers, and this is actually a project that Manav was working on in his undergraduate research in our lab. There's a few circulating biomarkers that are also okay predictors of the risk of preeclampsia at 12 weeks. So the problem with that is both of these things, both laboratory analysis right now, they're basically ELISA-based assays to quantify the circulating biomarkers, and this is a Doppler ultrasound device, which is fairly expensive and also requires training and expertise to extract and analyze these data. Both of these are sort of high resource solutions. So one of the things we're doing in our lab, I'll go through this fairly quickly, but we're developing a fluid solid growth model of the maternal vasculature throughout pregnancy. In fact, if you hear the fan go off on my computer, I'm actually running a code behind this presentation right now to develop this model and to identify certain markers. And here's what our model sort of predicts as this center line velocity, and then the pulsatility index versus gestational age. And so the blue dots are our experimental data. I think it's across about 45 different papers of measuring pulsatility index. And what was remarkable when I made this figure, I was sitting with my graduate student. I said, "This is like incredible how tightly regulated this pulsatility index is across studies from around the world." And then the black line is sort of what our model predicts from these curves. And so the point of this model, though, is can we identify markers in other locations that are more easily accessible and don't require high resource tools? So that kind of develops us, kind of leads us to sort of this next couple of things. So we're getting ready as soon as we can get back to Ethiopia. Actually, when I was there in March, I went to Ethiopia and I went to Nairobi. When I was there in March, I was planning to go back to Ethiopia and actually initiate the training of our team for this study. And we actually weren't able to get back because of COVID, and I haven't been back since, unfortunately. But we're running a detailed study where we're really going to carefully quantify the maternal hemodynamics longitudinally throughout gestation in about 400 women to really validate our model with the goal of developing lower cost markers. One thing that we're really interested in, it's called pulse wave analysis. So we can all feel our blood pressure pulse if you put your finger on your radial artery or on your carotid artery or your femoral artery or even your fingertip and even your earlobe, right? There's a lot of sites around the body that we can if you can feel it with your hand, we can develop a low cost tool to actually measure it. In fact, there's a lot of tools out there already that could measure these things, right? Like smart watches. So can we use simpler technology to still assess the risk of preeclampsia? So that's kind of the big picture goal of this project, and that project's funded right now by the National Science Foundation. And I know we're getting close to time, so I just have one slide on this. This was something that you guys may have, I think, Manav mentioned at the beginning with our Gates grant, actually just getting started. This is on the neonate side, and so neonatal mortality remains among the highest in the world. And I mentioned in 2010 we had these really high child mortality rates. Actually, over the last 10 years, we've done a pretty good job at reducing. Child mortality rates. We've done a pretty good job at reducing child mortality worldwide. Maybe since 2010, it's probably been cut at least in half, but probably more than half. But if you look at the neonate mortality, it's almost flatlined. It's almost level. There's been maybe some modest improvements. In neonates, that's the first 28 days of life. Neonatal mortality in Ethiopia really hasn't changed much in the last 5 or 10 years. There's a bunch of different causes for neonatal mortality, but I think a lot of them are centered around it's actually considered an indicator of the sort of the level of the healthcare settings in those countries and regions. And so what we're interested in this project is actually just monitoring some vital signs. So Hong Yeo is a professor in mechanical engineering, and he develops these wearable sensors. And so this is a picture of one. It's a patch that sticks on your chest like a Band-Aid, and it can do EKG. It can sense respiration rate. There's sensors in there that as you breathe, it stretches. It's stretchable. It's a stretchable device. And we've also, so it can do heart rate, it can do temperature, it can do respiration rate, and it can also now do pulse ox. So it can measure blood oxygen concentration, all in a single patch that sticks on the chest like a Band-Aid. And so we had the idea or we asked the question, it was sort of developed, I think primarily for more of a, so almost like a Fitbit watch, like more of an exercise training device, but also for clinical applications. We had the idea of, well, what if we developed a wearable biopatch that a neonate could wear for the first 7 days of their life? This device communicates to a simple smartphone or tablet, and so it gives those readouts continuously. And with these four indicators, we can detect many of the causes of neonatal mortality. So we were awarded a Gates grant this over this past year, and as soon as we can go back, we're hoping to go back early 2021 to actually initiate a pilot study to assess the usability, the feasibility of these devices, and also the manufacturability of these devices in Ethiopia. So, man, it's been a great journey these last 10 years. I've loved being able to take students and faculty and friends and colleagues to Ethiopia to just engage in research and service and teaching there. This is just a snapshot of a few, but we've probably had several dozen, maybe 30, 40, 50 different people with us in Ethiopia over the years. And it's been awesome. So here are just a few of my funding sources, but maybe now's a good time just to pause and have some questions or just some discussion. Let's see if I can find you guys.
Yeah, thanks so much. That was great. I think we have some time, so you can just unmute yourself or use the chat if you want. But yeah, I actually had sort of a general question on a broader level, but a lot of these, the CPD device or the preeclampsia tool or this wearable technology, they're all sort of new technologies that you're developing or adapting for people in Ethiopia who, like, it may not be commonplace to use these specific technologies. To begin with, what kind of challenges do you encounter in getting people to adopt it and incorporate these new technologies into work that they're already doing? Because that's sort of a problem that I know, like in our project in Engineers Without Borders, we've encountered issues trying to get people to necessarily use things and change their use habits to fit what we want. And I mean, I don't know what the best way to handle that is, but I was curious.
Yeah, yeah, that's a great question. Just about every grant that I write now on this work and just about every project that we do, it has a really big component and even a study. I didn't present much of it now. We actually haven't really completed anything on it quite yet, but over the next year or so, assessing sort of the usability of it by a representative end user, and not just looking at it and saying, okay, they can use it, but actually quantifying that, doing a study around assessing usability of a device and getting both sort of more informal but also formal and quantitative results based on usability. Also, another big issue sort of around that is sort of beneficiary acceptability. So there's so many things that we may never guess before going into a clinical study, but maybe the mother just doesn't like a baby having a something on its chest, and it's just not uncomfortable, and there'll be a lot of pushback by the end users for having a something on a baby's chest. One thing we found that we kind of anticipated, but the first prototype we brought over and just showed people, nobody liked the fact that you could see the electronics on the outside, right? But they said if you just cover that up, then it's great. Nobody's going to be worried. So usability, acceptability are two really big parts, and that's a process, and sort of using this sort of human-centered design approaches to doing that. Another thing you mentioned that was really important was how these devices will be integrated into the workflow of the end user, right? So we could have this great CPD predictive tool and it perfectly predicts women that are at risk of CPD. But if it costs a nurse an extra 15 minutes for every patient they're seeing, it may never get used, right? So understanding how this could be integrated into the workflow of the end user is also really important and something to study and quantify and characterize and understand those barriers. So yeah, it's a really big part of this stuff.
Awesome.
I think Clinton's got a question.
Oh yeah. Hi, Dr. Gleason. Great talk. I actually took your class over the summer.
Yeah.
Um, so my question, it's kind of long, but I'll try to keep it short. So as engineers, we're kind of told not to think about financial or resource constraints when thinking of innovative ideas because they might limit us in terms of creativity. But as an engineer focused on global health disparities where there are generally a lack of resources available, how have you been able to shift that way of thinking to still generate ideas?
Yeah, that's a great question. I think there's two big things I always think about as it relates to cost, um, and two big barriers. I think just sort of generally, right? If it requires disposables, right? So then that's usually not going to be sustainable, right? So I'll give an example, like in the U.S. With an EKG, right? We put these EKG tabs on here, and then we snap on the electrical cords, and every hospital you go to, that's how they do it. It's nice because the tabs make nice surface contact and the snaps hold the cable on there, and so as the patient moves around, they don't fall off, and it's actually great. But when you go to low resource setting, um, essentially those tabs aren't available, and so they can't really use an EKG because they don't have the disposable pieces, right? So one big concern is disposables and where those are going to come from if you require them. Another good example, not to diverge too much, but the fetal heart rate monitor team, the first capstone team, there is a fetal heart rate monitor device that they actually have them in the hospital, and it's a really seems like a really trivial solution probably for everybody on this call. They've got what's called a CTG, and there's these little low-cost ultrasound pucks that go on the mother's belly, and there's some cables, and the CTG then prints out sort of the heart rate and the uterine contractions during labor, and then the clinician looks at the printout, and with that printout, he or she can interpret what whether if the fetus is in distress or there's fetal distress or there's some other concern. The problem is these beautiful CTG devices don't have the paper because it's a specialized paper that only fits in the CTG device, right? So it's another sort of consumable part that you know that is limiting the usability of it. So that's kind of the consumables story, and then just the resources story. So electricity, right? One of the limitations of the Kinect device is it had to be powered all the time. And even though the iPhone and structure camera require charging, they don't need sort of continuous power. And so thinking about in terms of resources, I think those are the biggest things is, okay, what's going to sort of stop this thing from being used even if everybody using it wants to use it. And yeah, for sure, cost like but I would rather have a $100 or even $500 device with zero consumables that you can use over and over again compared to something that costs $1, but you have to continuously resupply it. I don't know if I answered your question or not, but
I had a quick question.
sure.
You mentioned how it's important to integrate all of these solutions to the end user, right? To the nurses, the people in the hospitals, etc. Uh, what would you say, in implementing these solutions in these communities? What's or in your experience, what has been the most challenging part in implementing it? whether it's them accepting the problem or accepting the solution, or actually the implementation itself.
Yeah, yeah, great question. I think it really depends. I think every solution I've probably got a different bottleneck. Give you just a couple examples. Like CPD, there's sort of some clinicians will just say, nah, you really can't predict it that accurately. You just have to, you just have to it can only be diagnosed at labor and you can't predict it earlier, so some of it is sort of just a disbelief in the solution. A big part is workflow and the end user. I Another sort of kind of like unbelievable example is, we were at a NICU in Ethiopia, and we talk about neonatal hypothermia, and sort of the protocol is when you transport a baby to, say, the NICU, when they're sort of in triage or when they're sort of being waited, when they're waiting to get admitted and get into an incubator, there's a radiant heater there that they're supposed to be using. And I visited that place 3 or 4 times, and every time I show up, the radiant heater's not on, and the clinician, the neonatologist I'm with, says, "Well, why isn't this on? And why aren't we using this?" And it's just sort of apathy of the staff for not using it, and it's just an extra piece of effort for staff that are already like totally overwhelmed and have too much on their plate to already do, so I think the best solutions are the ones that actually reduce the time that they have to spend on patients rather than increase it. So, but like I said, every solution probably has a different barrier. And I think the key is trying early to identify what the barriers are, because you're not gonna intuitively know until you actually try it and see and get feedback, and you know.
I have a quick question, if that's all right.
Yeah.
Ignore my bad lighting in the back here, but I was wondering, you described whenever you go over to Ethiopia, specific partnerships that you work with whenever you're, pre-design, doing the human-centered design and also implementation. I was wondering what those specific partnerships look like. Do you typically work with hospitals? Are you able to work with the staff that you just discussed, or how does that look like?
Yeah, great question. Like, anytime you do anything, like even if it's a project for a class, right? This stuff really comes down to relationships. And developing relationships cross-culturally, you guys all know, is just harder. It takes um, Ethiopia specifically. It's a very social culture. Sitting down and having lunch is really important, and having time just to sit and have coffee, like coffee in Ethiopia is amazing, and so it requires a lot of time and commitment. So over the last 10 years, so every year I probably spend about 3 to 4 months in Ethiopia, except for this year. I haven't been since March, but that's definitely by far the longest that I haven't been in Ethiopia. My whole family and I go over the summer for a couple months, and then I'll take 4, maybe 5 trips throughout the year. And then also having uh, others of my team on the ground, so PhD students or undergraduate students or whoever, um, to develop and foster those relationships, and just be engaged relationally with people is really a big deal. Um, the partnerships that my projects are all done through, it actually varies. It actually varies also. Most of the projects I've done so far have started. I've worked at a hospital in Ethiopia called Black Lion Hospital, Tikar Ambessa Hospital, and so most of my relationships are with clinicians there. So several obstetrician gynecologists, pediatricians, neonatologists, infectious disease guys in internal medicine, and so mostly it starts at least for me now, most of the projects start with me and a clinician kind of sort of co-inventing an idea or a solution. So the baby warmer solution, the first thing we did was the senior design team went and interviewed a bunch of clinicians, but it was really one clinician that sort of helped lead that project, and now we're continuing to work through that. Also work with some NGOs, nonprofit organizations in Ethiopia. Some of our projects work with them. We've got a project with the Ethiopian Society for Obstetricians and Gynecologists, and there's some others there. But in the end, it's usually just a person or a couple of people on a team, and then that leads to, okay, how can we roll this out, and who else do we need to bring in? And again, it usually depends on the solution. As we go forward, we look for bigger sort of networks and bigger platforms to integrate some stuff. I was on a call this morning. Emory has a big footprint in Ethiopia as well, and so they've got some programs that some of our solutions and devices may be able to plug right in and have a broader reach and a broader impact when they're ready for a larger scale study. So yeah.
Yeah, that makes sense. Thank you for
Mhm.
answering that.
Sure.
I think we are pretty much at time, but thank you so much for everything, Dr. Gleason. Is there any place that we can do, like if students have any more questions or want to learn more,
Yeah.
is there a place that I should direct them? Should I leave
Yeah.
a chat?
Yeah, usually email is the best for me. You can find my email on the BME webpage, or I mean, we can put it in the chat too. But email is great. We always have undergrads. I think we've got 20 some undergrads in our lab now doing research or so, and also looking for graduate students interested in doing this as sort of a PhD or some type of sort of post undergrad research. So if you're interested in those types of things in sort of the space that we're working in, feel free to reach out as well. Yep.
Awesome. Thank you so much for everything. Yeah, we really appreciate it.
Yeah, it's great. Thanks for putting this together. Thanks for trying to keep EWB moving forward in the crisis. So it's really important. Thanks, guys.
Awesome.
Good to meet everybody.
Have a good evening.
You too. Bye-bye.